Global health financing is a complex and challenging field that aims to improve the health and well-being of people living in low and middle-income countries. Health aid, or the financial and in-kind resources dispersed by major development agencies for health, has played a significant role in supporting domestic financing and achieving historic gains in global health. However, health aid also faces various problems that prevent it from being more effective, fit for the future, and aligned with country priorities. In this paper, we propose a new model of global health financing that aims to address these problems by refocusing health aid at the margin, i.e., supporting services that would otherwise not be covered by domestic funds. We also discuss the benefits, feasibility, and implications of this model for both donors and recipients. The authors identify 6 major challenges that hamper the effectiveness and sustainability of health aid: funding volatility, aid fragmentation, the displacement of domestic finance, ineffective prioritization, the lack of transition planning, and the lack of country ownership. These challenges have been exacerbated by the COVID-19 pandemic, which has created new fiscal pressures on both health aid and recipient countries. We argue that these challenges stem from the current approaches to global health financing, which often target the most cost-effective or donor-preferred interventions, rather than supporting countries to have strong and effective prioritization processes and systems. We also argue that these challenges undermine the democratic principle that decisions on public services should be made locally, not by external actors. The authors suggest that domestic finances should support essential health services and health aid should primarily be used to expand the package of affordable services at the margin. That is, the core package of the highest priority, most cost-effective services should be fully supported by domestic finances. Instead of targeting the most cost-effective interventions, donors should support countries to have strong and effective prioritization processes and direct any financial support for health services to the next most cost-effective interventions, i.e., those that would otherwise not have been covered by domestic funds. This marginal aid approach would require effective evidence-informed priority setting, EIPS, systems to assess the expected costs and effects of health investments and set up a single national health benefits package that is aligned with the total expected health budget from domestic and aid sources. The authors explain how marginal aid would address the 6 challenges of global health financing by reducing funding volatility by aligning aid with domestic budgets and priorities, reducing aid fragmentation by pooling and coordinating donor funds, reducing the displacement of domestic finance by supporting services that are additional to the essential package, improving prioritization by using EIPS systems and evidence-based criteria, improving transition planning by using predictable and gradual exit strategies, and improving country ownership by empowering national decision-makers and policy processes. We also explain how marginal aid would offer other benefits, such as increasing overall health for the money, facilitating a seamless aid exit strategy for thriving countries, ensuring the sustainability of financing for countries that continue to need support, and respecting national preferences and values. The authors provide a hypothetical example of how marginal aid would work in practice in a low-income country with high disease burden and low domestic health spending. We illustrate how marginal aid would help the country prioritize its health services based on cost-effectiveness and equity considerations, and how it would allocate its domestic and aid funds to cover the essential package and expand the marginal package of services. We also illustrate how marginal aid would help the country plan for its transition from aid dependence to self-reliance, and how it would benefit from continued donor support in technical assistance and global public goods. The authors discuss the feasibility and implications of implementing the marginal aid approach in the real world. We acknowledge that marginal aid would require significant changes in the behavior and incentives of both donors and recipients, as well as substantial investments in data systems, EIPS capacity, and governance structures. We suggest that marginal aid could be piloted in a few countries with strong EIPS systems and willing donors, and then scaled up gradually based on learning and adaptation. We suggest that marginal aid could be aligned with existing global health initiatives, such as the Global Financing Facility, Gavi, the Global Fund, UHC 2030, etc., to leverage their expertise, resources, and networks. We suggest that marginal aid could also be complemented by other innovative financing mechanisms, such as debt relief. The authors suggest that marginal aid could also be complemented by other innovative financing mechanisms, such as debt relief, blended finance, results-based financing, etc., to mobilize more resources for health and improve efficiency and accountability. The authors conclude that marginal aid is a promising model for reimagining global health financing that could strengthen health systems and future-proof aid financial flows. We call for more research and experimentation to test and refine this model and to explore its potential impact on global health outcomes. We also call for more dialogue and collaboration among donors and recipients to adopt this model and to make it work for their contexts and needs. We believe that marginal aid could offer a new vision for global health financing that is more effective, sustainable, and respectful of country ownership. The link to the full paper can be found in the description of this video.